Space femur, male space tibia. We meet. Find it. Yeah, we meet right there. There's female space right across. Let me just pull up so you can visualize where it is. Looks like we have a little scar. Is there a scar there?
Yeah.
Yeah. So here's tibia. We come up, and here's female space. The point, if it's there, it's pretty unpleasant. That's medial meniscus point, right? Some people have it way anterior. Not so bad there. No. Some people get it right behind, close to the patella. Other people get it further down posteriorly back there. That's not happy. But the one in the middle is really the least happy of them all. And then we have the lateral meniscus points, do we not? So we douse the lateral line, and we've got that point. No, that point.
That one.
No, a little bit, but it's really not
Nothing like
hot.
medial points.
Yeah.
Did you have surgery at all? I had surgery when I was 13.
So, is this the only thing I would do with her?
No.
No. So we've done a whole potential. I've perhaps treated the male and female space. I've done the piece where I'm holding and balancing. I'm looking at the whole unit of function. Blah 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 blah. This is the part where I'm not happy. So if I'm where Malou is, do that the regular hold from where I'll hold that. Where you got one hand, yeah. So you got one hand there, or even one hand up here and one hand down there. You've seen me do that a bunch of times.
Now you're filming yourself.
I'm filming you.
I know you do.
That's right. Film myself.
You
Hello.
gotta look for melange.
There. So, and we do that. And we're really looking at it as a combination of male space, female space, and trying to treat the whole thing as a unit of function. Now realize that the ACL vector and the PCL vector are all in this thing, right? We're looking at compressions. We add the counterstrain when her own inherent forces aren't sufficient to resolve that. We put that external vector force in. So that's already gone by, right? We've already treated. We made the decision that there just isn't quite, and she's saying, maybe we think our treatments are the best thing since sliced bread. And she's saying, I still have this knee pain. So at some point you got to give up just treating with the axes of perfection and say, let's roll up our sleeves and dig down into the real space of physical healing and counterstrain at SC3 and you go, gee, what about that point, right? Yeah, it's a nasty point. And if you look at it, if we were to douse her, that drops right through. It's a vacuousness to it that isn't there. If she had a piece of titanium in there, we'd be doing a biofield graft or something, but she doesn't and we ain't. So the revision for this, the revision for the medial and lateral are essentially the same. The rotation is probably different. Slide over toward me, Dia. Lift up your head, please. Good. And what we're doing, drop that leg, please. What we're doing is we're taking the leg out and basically we're just dropping the knee to 90 degrees, right? And then we're going to go past 90 degrees and we're going to put, now this is where I raise my table. I can control the amount of flexion by having a table. This table's down, I think, almost all the way.
Are you're past 90?
Yeah, I've gone past 90. I'd get over on the other side of the table so you can actually see what I'm doing. So, and I'm finding the joint line there and finding the tender point. How's that?
Pretty tender.
Still pretty tender.
Yeah, I would say 6, 7.
How's that?
5.
Okay, so at least by flexion, I'm reduced it. And now I'm going to externally rotate the tibia on the femur. Ask her how that is.
4-ish.
A little stronger. Now look at my hand on her heel.
3, 4. 3.
Okay, so we're moving in the right direction, are we not? So I'm internally rotating her thigh a little bit. I'm using my leg to lift the tibia away. I'm going to see if no, that made it worse, doesn't it? Yeah, good. So we've an answer that she doesn't like internal rotation at all.
Feels like it's
So we're
right
going-
on the edge of what I can stand.
But when I externally rotate it, strongly, so I'm locking my arm and I'm leaning in. Okay, how's that now?
2.5.
So drop it down just a little bit. I'm externally rotating the tibia.
Leaning in means you're leaning up towards the knee?
I'm pulling my fingers back toward me.
So
Back.
When I say internally rotating, what am I referring to?
Going towards.
But I'm sorry, I'm externally rotating. What am I externally rotating?
the leg.
Lower leg.
The what?
Tibia.
It has to be something on something else, right? So I'm externally rotating the tibia relative to the fibula, right? I mean, femur. So now one of those F bones.
Femur.
How's that now?
2.
Good. A little more external rotation.
Still 2. That's even a little more sore, actually, that much.
Drop a little bit. How's that?
2. Big 2. Bounce back and forth.
We're going to leave it at 2 for a little bit. Now what I want you to do is to push your leg gently into my leg. And release. Oh. Gone?
1.5, 2.
Okay. I want you to push your foot toward the floor, like turn it a little bit. That's good. Not too hard. Not too hard. And release. That's better. How's that?
1.
Is that acceptable? Or should we keep
Yeah,
going?
I think that's really good.
Are you so you're lifting it just a skosh?
No.
Lifting is no. That's too general of a term. I want it in anatomical terms so I get something relative to something else. What I'm doing is I'm actually increasing flexion, okay, and I'm increasing slightly the internal rotation of the thigh. So I'm using her leg and I'm slightly, look at what I'm doing. So if her thigh is fixed and I lift the foot, see where I'm going? Look at her thigh. I'm internally rotating her femur. And I'm driving my thumb in, pulling my finger back, and I'm externally rotating the tibia and it's gone, right? Good. Took me a while to get here, right? A lot of vectors to manage, but worthwhile point. There are a couple of other. Now I've mentioned torn cartilage. There's a handful of other conditions that will produce joint line pain that we can totally reverse with this. Some that have to do more with the joint capsule or having to do with the ligament that runs around the outside of the joint line. Waiting for breath and flow. It's gone internal. Feel how, if you can, how it feels like everything's sucked inside of her knee while I do this. So it's like gone internal. It's almost like she's in a still point. She's in a big pause.
And this is medial meniscus?
This is medial meniscus. There's the point.
Oh, the thumb.
Yeah, thumb's just hanging out, monitoring. Thumb's hanging out while my third finger is monitoring. I've given you a little dimple here, but
I'll give you some article later.
me?
There's nobody to report you to now.
That's right. You guys. There's breath and flow. And look at the point. There's no deviation or field.
No void now.
A little dimple right there. See that?
And you slightly just like.
Yeah. It's not so slight. I mean, she's softened, so she's letting me do it. She had so much fibrosis in her joint capsule, she wasn't letting me turn it out. That's why I had her push into me a bunch of times and really kind of tweak this until finally I could really get it to externally rotate
She was
well.
pushing down into your.
Yeah.
First pushed against your leg, I think, and then
Yeah, first she pushed against my leg, and then if I could, what I'd do is have you push your feet down to the earth. No, here, sideways, right into me. Yeah, so now I'm having her resist external rotation. Relax that. And now I could take up a little more slack.
Oh,
So,
there with the devil.
Yeah, totally true.
Funny.
Slowly out, eh? If it were the external point, right? Probably what you'd find yourself doing is internal, same position, you'd be internally rotating the tibia rather than externally rotating the tibia.
The thighs the same.
Lateral meniscus, yeah. Beg pardon?
The thighs stay.
This, yeah, everything else is the same setup.
You just have the straight down.
Mm-hmm. What? You talk about?
But there's more, so.
I would be internally rotating the tibia on the femur,
Okay.
on the lateral meniscus, versus externally rotating the tibia on the femur for the medial meniscus. Okay?
Now get out of it.
Yeah.
I got you.
Slow by slow is right.
That's the point.
One-ish.
Good. Now, should you be really surprised and upset if you put them back and it still really hurts?
Probably.
No.
Should be upset.
What would be the scenario if there really were an internal medial meniscus tear?
It would still hurt.
We could probably neutralize it with the position. As long as they're in that position, when you bring them back, it might hurt again. Diagnostically, it'll give you a sense of where you're headed. If you see somebody and they're trying to avoid getting an MRI, and you're trying to give them good advice, and you can make a lot of the points go away, and this one won't go away, and you can get it to go away while you're positionally shifting it, and you keep bringing them back. As a friend or as a professional, at some point, if this point persists and their knee isn't healing, it'd be time to suggest that they get an MRI and maybe see an orthopedic surgeon that you trust. Because arthroscopy might be in their future, or a PRP injection, or God knows what else is going on now. Okay?